Right. So I'm going to just go to the few basic things again, and some of it I'm sure would be a repetition. So what we're going to do is we're going to talk about a bit about local debridement and how do you approach the non-unions which we think need bone grafting, and maybe talk about a bit about bone grafting actually. So if you look at the classifications, there are two types of things we use in a day-to-day practice. Hypertrophic, which we frame surgeons call stiff because Elizarov said so. And it's actually, there's a very good reason why we do so. Or there could be a mobile or a oligotrophic or atrophic non-union. Now, for the purpose of this talk and also as a clinically, I think we can say that oligotrophic and atrophic is probably kind of similar thing. And then you have pseudoarthrosis, which we talked about it a few times, and it's quite uncommon, but can happen. And what happens in pseudoarthrosis is that you get a synovial membrane, it becomes like a joint, and that is one non-union which will never heal on its own. We always say the non-union, if you leave it long enough, will heal, but this is one which won't. So this is a sort of, when I say middle-aged, about 40, 45 chap, had a major trauma, and he ended up with a nail, and he had a classic pseudoarthrosis. He's the only one I've seen, and if you see, he could put his leg around his head. And it was completely pain-free. He can walk around, no problems whatsoever. And so he was the one, and what you do, you have to do an open procedure in it. You have no choice but to excise the bone ends. It will end up inevitable shortening, which you did in this case. We lengthened him later on, stabilized him with another nail. It did a while ago, actually, but if I do it now, I'll probably put extra plate on that. But I was lucky, he healed, and actually bone grafted him. So he healed all right, and he was fine. So when do you actually have to open a non-union to debride? So one indication is pseudoarthrosis. If there's a soft tissue interposition, especially when it happens if there's a transport and the skin is going in, and that's one reason you have to do that, or there's a possible infection. But apart from that, there's really no other indication which I can think of that we need to open a non-union site for debridement. Now, a traditional approach for non-union is you excise the ends, right? Freshen it down to bleeding bone, and this is another contentious topic which we can talk forever. Bleeding bone, the paprika sign, I don't know how much you take out and how do people realize. I find it very difficult when I used to do. And basically, because the concept was the bone ends are dead, so excise them, and then bone graft and stabilize. That's a usual approach. Now, we say non-union has to excise because there's a fibrous tissue. However, when we lengthen, there's a fibrous tissue in the center of regenerate. We never go back and excise the central zone of regenerate. We never do that. All we do is just wait, optimize the mechanics, and let it heal. So why fibrous tissue in non-union has to be excised, not in the regenerate? And so why do we have to freshen the bone ends? Because we think bone ends are dead. There is the vascularity, right? And that is the reason that they should be grafted, because ends are dead, and there is no vascularity. So let's look at the vascularity of the non-union. If you look at the vascularity histologically, there is actually enough vascularity for bone to heal. And there are a number of animal and other studies. They have looked at the MSCs and looked at the number of MSCs in the non-union and the bone marrow in the same patient. And they actually found that there is hardly any difference in the mesenchymal stem cells at the non-union site or through the bone marrow or of the bone graft. So which basically means biology is not a problem. So then the question arises, is there a avascular non-union? Does it exist? I think not. Possibly maybe one or two when there's a bone gap. But apart from that, if there is a bone ends are in contact or a bit of fibrous tissue, I don't think it actually exists. Now, let's look at the cellular components of the bone grafts. So we go to pelvis, we hack a lot of bone and took an autograft. If you look at it, the count of the bone marrow, the cells actually is quite low in the autograft. And we use all these cells to go in and put it in with a low number of cells and expect it to heal. And if you look at the literature, we actually don't know that bone grafts actually does anything, because there are no true markers in as such for us to know that what we're putting it is actually works or not. And we put it in, whether our intervention heals, or to be healed on its own, or stabilization, restabilization heals, we actually don't know. So there's no clear evidence for that. So if you remember, Chris Moran's published this paper a few years ago, and he's a great plater. So he did judo decortication on non-unions and fixed it in situ with the plate. And half of them had bone grafting, half of them didn't have bone grafting. And the only time he excised the ends was with the very mobile bone grafts. And then if you look at the union rate, it's no difference. And that is the chart if you see how they decrease the bone grafting in the unit. And that was a while ago, actually. And they concluded that routine use of bone grafts in non-union is not necessary. And in clinical practice, if you look at it, you have a huge emphasis on biology. And all we do is, any non-union, say, any trauma meeting, anywhere in the world, they say, I'll bone graft it. I'll bone graft it. And the question then comes in, that is it really important? And because the thing is, we have grown up with the thing that non-union must be bone grafted. We need to look at evidence. And I always say, ask yourself a question: why I'm doing it? Is there a genuine reason? Is there a scientific evidence? Or I'm doing it because somebody told me to do it? How do we know that in their time and age, probably it was right, because the understanding wasn't as good. Now we have better understanding of the cellular biology, the basic science and mechanics. We are in a different situation. So let's look at the atrophic non-union. So there is a mechanical stability we need, and we need a biological stimulus. So why this biological stimulus has to be bone grafts? We can alter the mechanics to rekindle the biology and heal the non-union. So this is a case of I'll show you this case, one of my cases. So this is a humeral fracture, had a lovely nailing, and it went into non-union. And I hope everybody agrees it's atrophic? Good, right, that's fine. So then they did it, they went in, did a compression plating, bone grafted it, and it comes out again like this. Is it an atrophic, hypertrophic? Atrophic, agree? Right. So if you see screws are loose, it hasn't come out very well, but if you look at in a monitor, screw comes out, screws were loose, it was evidence this was non-union. So all I did was, left everything there, put in a frame. Now normally I'm not an upper limb frame person, but this is just to stabilize. Close treatment, no bone grafting, no opening, nothing. All we did was stabilize, optimize the mechanics, and it healed. Right? So what we need to do is we need to optimize the mechanics of it rather than actually looking for the bone grafts in every case. And this is Nando Ferreira. He looked at all the non-unions in his previous job in, I always get it wrong, Pre-Mattisburg, wasn't it, where he was working. So he looked at it. So if you look at it, he had 180 non-unions, and out of which significant number had high risk factors, right, in eye. And what he found was that in atrophic non-union, all they did was compression. They did not routinely open the non-unions, and bone grafting was done only in cases where there was bone loss, right? Which is, we understand we'll have to do it. And in hypertrophic, they just distracted with no bone grafting. And if you look at the healing, 92% in one go, had some non-unions, second go, 98%. This is a pretty good result. And healing time, pretty much similar. So mechanics are quite important. And this concept is not new. It has been proposed a while ago, and Carter proposed that how the mechanical forces alter the biology and the body reacts, that is quite important. And actually, we missed it. And if you look at the original paper from Oxford, from, what's the name? Ken Wright's paper. So we all talk about a micromotion, but actually there was another bit of it, which is that if once the callus is there, you need to hold it stable and in a stiff position until it heals. We actually missed out completely. And we know nobody talks about that. So there's more than, people have understood and described it a while ago. So what Elizarov said, Elizarov basically said, stabilize it, straighten it, load it, and it will heal. And that's what it happens actually. Because there is evidence that it proliferates osteoblasts, the basic biology is improved, and it heals. And there are a number of ways you can see there are manifestation of growth factors. And so all that, by just optimizing the mechanics, improves and helps the bones heal. So it also does is, it also generates some electric current. And on the concave side, it is negative, as we know that heals better, right? And on the tension side is osteoclast stimulated, and therefore it doesn't heal as well. And we can manipulate that. If we know that mechanics generate electric currents, then we can optimize it for in our advantage and in a way, so it helps us heal the bone. So when do we do actually bone graft? One, when there is a gap, we know we have to bone graft it because there's no option, osteoblasts don't jump, right? So all the other localized or any cases where the bone loss is an absolute indication. Possibly when there's a recurrent non-union, poor vascularity, where you think that despite the bit of soft tissues there is a possibility, a poor biological environment, there's another thing possibly you can think of bone grafting. So this is a gap non-union, and if you look at it, the only way it will heal is by doing a bone grafting. And one of the things I've learned in my life, the older I'm becoming, I have come to realize I really don't know anything. So thank you very much. To summarize, I'll just go that you need to optimize the patient. Patient optimization, all the things, smoking, diabetes, and NSAIDs, all that is there. You do not routinely need to debride the non-union site, and you do not routinely do the bone grafting. If it's an atrophic non-union, you need to align, compress, stabilize, optimize the mechanical environment, as biology is rarely an issue. And there's a lovely algorithm which Nando Ferreira has published in Injury, and if you want to follow it, it's actually quite good. It's a good article. Have a read, and thank you very much. Please fill your evaluation forms. And I need to, just a couple of things. So there's Asami next year in Beijing. So it's a lovely place, lovely meeting. If you want to go to China, it's a good time to go and good place to go, right? And there is a Sheffield Masterclass in September this year. So all the pediatric guys who want to go, it will be a very good opportunity. It's a fantastic faculty, and it'll be a good opportunity to go. Thank you very much.